So, a very good morning to all the doctors who have joined us today for this panel discussion webinar titled Isotretinoin Insights Unpacking the ERAISE ACNE Consensus. At the outset, I would like to congratulate all the authors for publishing such a landmark paper on using isotretinoin in the Indian context. And we are extremely glad to have some of the authors join us today for a panel discussion. To moderate today's session, we have with us Professor Dr. Jayakar Thomas. Sir is a senior dermatologist, director, and emeritus professor at the Department of Dermatology, Chettinad Hospital, Chennai. Sir has over 300 and counting publications. Joining us on the panel is Dr. V.K. Somani, senior dermatologist with over 40 years of clinical and academic experience based out of Hyderabad. Also joining the panel is Dr. Manjunath Shenoy, consultant dermatologist, professor and HOD at the Yanpoya Medical College, Bangalore. Thank you so much, doctors, for taking a time out today to join us on this panel discussion. And over to Professor Jayakar, sir, to moderate today's session. Thank you, sir.
Thank you very much, Dr. Ashley. And permit me to share my slides. And while I'm doing that, I'm really grateful to Messr Cipla for giving me this wonderful opportunity to make a presentation and to moderate the session. And more particularly to Dr. Somani and Dr. Manjunath Shenoy, who've been very kind to accept to join me. They are two wonderful people who are very good in their subject. Particularly, I know because they have been working with me and discussing with me on isotretinoin and in management of acne, several platforms. Am I audible and are my slides seen?
Yes.
Yes, okay, fine. Now this is basically on the paper that Dr. Ashley just mentioned, the expert consensus. We called it the ERAISE, and it was a Delphi consensus process. And this slide just shows how the entire process went on, how the panel selection of 20 experts from across the country were expected to work on this. Not that we don't have more than 20 experts, but that we have to start somewhere. A lot of things took place before we really came to the Delphi survey, and we had a lot of discussions. More than one round of discussions before we really could come out with this statement. And this statement has been published in Dermatology Therapy, which is a very unique journal in terms of therapy. Now, to set the context, the ERAISE ACNE consensus is the first detailed Indian guidance which all of us can be proud of. All of us as Indians can be proud of, not only the authors, just everybody should be proud of this. And let's look at what were the most significant practice gaps this initiative set out to address, and how the real-world prescribing patterns among the panelists shape out the final recommendations which we are talking about, and which will be spoken more so by my honorable colleagues, Dr. Somani and Dr. Manjunath Shenoy. The expert consensus on the use of oral isotretinoin, as you see, for use for all three formats, mild to moderate and severe. And those which are marked with a green bullet only shows the strong recommendation from the panelists and the poor consideration. And we look at the poor consideration because whatever is strong mostly will be accepted. So with a strong family history of scarring, regardless of the grade of acne that we are looking at. Even in the mild forms, there were a few dermatologists who said we cannot consider the use of oral isotretinoin when there is a strong family history of scarring. And then going further, whether recommended in pediatric use or only in adult use, we find that all the boxes were checked in the case of adults, that is those over 18 years. But when we looked at the pediatric group, somewhere between 12 to 18 years. We did notice that moderate to papulopustular acne with the risk of scarring again. So scarring seems to be a big factor, a common factor when it comes to moderate consensus and can be considered not strongly but very, very weakly. Now, why is that happening? We'll discuss in a short while from now. Now, with regard to the patient selection for the study, the consensus strongly recommends use of isotretinoin profiles beyond the traditional severity-based thresholds. What does that mean? Now I will need the help of my colleagues from here onwards. Dr. Somani and Dr. Manjuna Chennai, please throw more light on isotretinoin endorsed as the first line of therapy for moderate acne with scarring risk, with psychosocial burden, with frequent relapses, and for cases of persistent acne. How do you gentlemen see this reflected in Indian clinical practice? Can I have your opinion, please? Dr. Somani could start, please.
Yes. Thank you, Dr. Jaikar. As I see it, yes, globally, it was isotretinoin was initially recommended, indicated mainly for nodular cystic acne and conglobate acne and severe papulopustular acne. But later on, globally, people, doctors, physicians realized that it could be used in many more situations, many more conditions with very good results and preventing further complications. And this practice was being followed globally now for quite some time. But in Indian scenario, I feel that there is a reluctance and a little bit of reservation in using isotretinoin amongst patients suffering with acne. Still, most of the dermatologists here would prefer to use only in real indications which are given long time back. The like I mentioned, nodular cystic and severe types of acne. But I think the presentation, what we had made, the paper, what we are discussing today, I think it has thrown some light over the usage of isotretinoin beyond the indications given, because there is always a serious risk of scarring lurking. There is a risk of psychosocial trauma and stress. So all these things have to be considered when you are prescribing isotretinoin. And I think slowly this is percolating in Indian practice, but still I think it has a long way to go, because the reservations and the reluctance to use isotretinoin still is quite rampant in Indian dermatology community. So I think this study will throw some light on that, and patients will be benefited more as more and more doctors would prescribe isotretinoin in different indications rather than the real old indications.
Thank you, Dr. Somani. That was really very pointing and very revealing. So I will request Dr. Manjuna Chennai to tell how one would recommend isotretinoin usage in female patients with recurrent acne and no evidence of relapse due to hormonal changes. Now, that question is a little paradoxical. When you say with recurrent acne and no evidence of relapse due to hormonal changes. Dr. Manju.
Yeah, isotretinoin usage in female patients with recurrent acne is definitely a go from my side, because although there is no evidence of relapse due to hormonal changes, considering the amount of scarring, that even these relatively higher severity, I would say papulopustular acne grade 3 or grade 3 in Pillsbury classification, even that is very much indicated to use isotretinoin for two reasons. Number one, we don't have any drug that prevents scarring, if at all, that is isotretinoin alone. That's one reason. And number two, because of the growing antibiotic resistance. So whatever amount of antibiotic we use, we do see a lot of resistance. Whereas isotretinoin is a different class. It is a sebostatic agent. It definitely does not interfere. There is nothing called resistance to isotretinoin. Only concern is a little bit flare, which happens in a small number of patients when we initiate. So we should not have any hindrance in recommending isotretinoin in female patients with recurrent acne, even if there is no evidence of relapse due to hormonal changes.
What can we tell our audience today when we talk about relapse due to hormonal changes? What is that all about, Dr. Manja?
We have good number of patients which are called, wherein we call it as a hormone-driven acne. which is evidenced by associated severe premenstrual flares. That is one category of patients. Number two, those who have associated features of hyperandrogenic, such as the hirsutism and maybe mild form of androgenetic alopecia. So in such patients, it's definitely a hormone-driven acne. And that is where we consider whether hormonal therapy is ideal or it should be isotretinoin. But in my experience, isotretinoin does work in such patients also. Because
That
of its
indeed
mode
is
of action.
a very important point when you talked about. All the time we were talking about PCOS. Now we know that the name is changed to PMOS, polyendocrine metabolic ovarian syndrome. So that is one thing that we must always keep in mind when we are going to treat female patients, particularly those between maybe 18 to 25 years. You have to be very careful about and check the history properly. It's not the menstrual cycle alone. Look at the other evidences that Dr. Manjunath correctly pointed out, alopecia, along with acanthosis nigricans, hirsutism, obesity, and things like that. That was good. That was good. Let's go on. We did talk about antibiotics. Both Dr. Somani and Dr. Manjunath did talk about antibiotics. Now, with regard to the use of antibiotics, we know that antibiotic resistance Cutibacterium acnes has been reported globally. It's not just an Indian scenario, it's globally. Do you encounter cases of antibiotic resistance in Indian clinical settings, and what is your strategy to manage these cases? Dr. Somani?
Yes, Dr. Jaikar, yes, you are absolutely right. The resistance is rising all over the world and including India. When I started my practice, about half of my patients, about way back, 40 years, 42 years back, I was mainly relying on antibiotics for moderate to severe acne. And of course, erythromycin never worked. Neither did azithromycin in my experience. But tetracycline group of drugs were wonderful and they work very well. So I always used to use tetracyclines or doxycyclines or limecycline later on with wonderful results for about a decade or two. And then slowly, even the tetracycline group of antibiotics stopped working, and I had to resort more and more to usage of isotretinoin as days passed. And now, off late, I can see that even tetracycline group of drugs also are not offering that much of results as I expected as I saw about 2-3 decades back. So the resistance is definitely rising. Erythromycin was never of any importance, never of any utility. And now tetracyclines also are slowly getting blunted by maybe too much of usage and the resistance rising all over the globe. And that is why we have to resort more and more to other alternate therapies, including isotretinoin in such cases. So it is getting more and more rampant day by day. That's my take.
I will give my comments on this after we hear from Dr. Manjunath Chennai about antibiotic resistance.
Yes. Yeah, I think we do see what I call it as clinical resistance because it's based on our observation clinically. If you ask me to say that there is an antibiotic resistance as a scientific person, we need to do antibiotic sensitivity testing, which is very difficult considering the Cutibacterium acne is a anaerobic culture, has its own challenges, and proving it in a regular clinical settings is difficult. But we do see failure of antibiotic therapy, both in terms of doxycycline, minocycline, and limecycline, which we don't use it very frequently because of the cost. It is because of that we don't use it routinely. But we do see failure with the antibiotics. And the strategy, in my opinion, again, when you have a severe papulopustular or nodular cystic acne, it has to be oral isotretinoin.
Yes. Now, actually, I wanted to say all these points which the two of you have said. Number one is, of course, in the absence of a proper lab diagnosis for antibiotic resistance of Cutibacterium acnes, and in the presence of so many antibiotics really not being effective. And we read so much in the books, we read so much in literature, and as Dr. Somani said, a student, everybody jumped on tetracycline. Now, tetracycline, they came to erythromycin, then again they went back to another form of tetracycline, doxycycline, and it kept on, minocycline and things like that. But nothing worked. So I would certainly say that there is no need for using an antibiotic at all, unless you find severe pustule acne, where you would like to give a short course of antibiotic to bring down the pustules. There again, we do not know whether the antibiotic is helping or whatever you add along with that is helping. So we can keep that antibiotic aside for the time being and think that we are not having antibiotics in the treatment of acne. Here is a recommendation that came further. Early initiation, obviously, now in the absence of a proper antibiotic or any other anti-acne measures, quickly we have to come to isotretinoin. I remember years or rather decades ago when isotretinoin, first I was only a postgraduate student at that time, when isotretinoin came into the market and people were talking so much about isotretinoin. The use of isotretinoin was there, but then they were also giving us a lot of fear on the use of isotretinoin because of the side effects. So many, not necessarily only in females. And anybody use isotretinoin, particularly the cheilitis that we talked about. The early worsening of acne lesions. This is another thing which was talked about. And for everything, what zeroed down to was quality of life. Quality of life. And in this ERAISE study also, we took into consideration all of what we have said so far. And early initiation of isotretinoin can prevent the progression of mild to moderate acne. I want you two gentlemen to please tell me how much of truth there is in this statement. Although the consensus has been moderate on that, I would like to have your individual opinions. Dr. Manjunath, early initiation of isotretinoin can prevent the progression of mild to moderate acne. Is that true?
So if we go through the evidences published so far, the first two and the last point, yes, they have a very strong evidence. The third point, probably the lack of evidence. And it's very difficult to comment on the progression of mild to moderate acne. We do initiate early, no doubt about that, isotretinoin, when there is a definite clinical indication. But unfortunately, we won't be able to come to what is called the cumulative dose of acne, which should be 120 milligram per kg, which is achieved over a period of, if you are giving 0.5 to 1 milligram per kg body weight, which will be typically achieved over a period of 6 to 8 months. The problem is there because I think most of us are not confident enough to do this particular cumulative dosing strategy. But in case we are able to do that cumulative dosing strategy, provided the patient is able to tolerate the adverse effects such as dryness and other adverse effects, probably yes, it is true. That's why I believe some of the investigators in this consensus, they must have thought, it may not be feasible to attend. That's why it probably had only the moderate consensus. That's my take.
Dr. Sumani, do you feel that early initiation of isotretinoin can prevent the progression of mild to moderate acne?
Yes, I mean, going by the experience and going by the molecule, the efficacy of the molecule, the working of the molecule, it is definitely a distinct advantage of using it early in cases of mild acne to prevent its progression. But I would, in my personal practice, first use topical therapy like benzoyl peroxide or tretinoin and other things, and along with the adjunctive measures, and try to control the patient with these things. If these conservative measures fail, then I would think of going on to isotretinoin, because we definitely want to prevent progression and prevent scarring, and especially when there is strong family history of scarring or strong psychological stress with the patients, that gives you one more reason to start isotretinoin in mild acne. But in general, my process would be to deal it with topicals first. If that doesn't help, then okay, then definitely I will think about using isotretinoin. Maybe in lower doses, a low dosage treatment of isotretinoin, as Dr. Manjunath pointed out, we need not go for full strength 0.5 milligram. We can go for 0.1, 0.2, 0.25 in such cases, if you really have to use it. But most of the patients, I think, they do respond to topical therapy. But if required, I wouldn't hesitate in using isotretinoin in my patients also if they don't respond to the routine conventional therapy.
Yes, I agree with the pair of you. Low dose. You said low dose, 0.1 milligram per kg body weight. Now, is it going to be feasible? Is that going to be feasible? Such a low dose?
In my personal opinion, Dr. Jayakar, I never use 0.1, 0.25. I always use 0.4 to 0.5 milligram in almost every patient. But in exceptional cases, we might use not point 0.1. 0.1 I feel is ridiculously low, but 0.25 to 0.3 milligram we can definitely use as a low dose treatment. But I always use between 0.4 and 0.5 in my patients, almost all my patients.
I agree with you. Point one is a joke. Huh? Point one is only a joke and it doesn't help at all. May as
Yes,
well not use isotretinoin.
true.
Let's go on further. The skin of color. That is one thing we as Indians are always worried about the disproportionate burden of post-inflammatory hyperpigmentation and scarring. How should the risk of PIH factor into the decision to initiate isotretinoin early? And how does one identify patients with risk of scarring to recommend isotretinoin usage? Dr. Somani, could you please continue on this?
Yes. First of all, yes, because the problem of PIH always factors in, and especially type 3, type 4 patients, and it's not much of a risk in type 5 or further. And that has to be taken into consideration. If there is too much of acne lesions, then that would be a big psychosocial deterrence for the patient if the acne continues further. So we definitely have to take that into account. If it is extensive and causing too much of PIH, we might think of starting isotretinoin earlier as an indication. And in addition to, of course, usage of sunscreen and other agents, what can reduce the pigmentation too. I think the second part of the question is very, very important. How do you identify patients with the risk of scarring? If we can have a very clear-cut way of finding out that the patient is going to go in for scarring, that would be definitely greatly helpful to decide whether to initiate isotretinoin in the early stages itself. So I think the history of the patients, look at the face, if there's scarring, even a few scars on the face, and with the history of mild acne, and then you see scarring on the face, it means that the patient is more prone to go for scarring. Family history of scarring is again very important. If you find that out, then definitely that's another indication for starting isotretinoin in moderate acne too. So we must identify patients who are prone to scarring, and then I think that definitely is one more sub a group where we can put the patients on isotretinoin relatively early in the treatment course.
Yes, that thing weighs heavily on the therapy of acne. Not so much about the PIH, because we know that that's a common thing and occurs so many other conditions and so many other therapeutic regimes. The risk of scarring, I do not know whether I'm not too sure whether I got your points correctly about the risk of scarring. How does one identify the patients? Dr. Manjunath?
Yeah, yes, sir. I think I'll take the second question first. How do you identify patients with the risk of scarring? The risk of scarring, 2 points that strongly guides me. Number one is the type of lesion. The nodules, cysts, they always scar. Severe inflammatory papulopustules, so they can scar. And then I also look at the parent's face. If they have, the child teenager is brought with the parent. And I also look at the family history of severe scarring, especially the father. Generally, the nodulocystic acne is more common in boys and men. So that is definitely, these are the things that risk, I mean, that points towards the high risk of scarring. And in such cases, definitely it is recommended that isotretinoin be started early in such patients. And second question is, how should the risk of pH factor? pH, as Dr. Somani rightly mentioned, in higher pigment grades like type 4, especially we see predominantly type 4 skin, there is a very high chance of PAH. I'm not sure if that's a PAH is going to happen in all inflammatory papulopustular lesions when there are. So in such cases, it may be worth topical therapy along with some of our aesthetic treatments like peels and PICO if you have MNRF or some of these. They can be, interestingly, we have a question also on that by our one of our audience. So I think that may be a good idea, but where there's a risk of scarring, if there is any drug that can prevent, is isotretinoin.
It's wonderful. I just want to again reiterate this point on hyperpigmentation. Now, there is a study which shows that isotretinoin is useful in cases of facial pigmentation, small doses, particularly when you are looking at what I would like to call today as melanosis secondary to seborrhea. So, in such cases, small doses, very small doses, 5 milligrams per day, would certainly help for pigmentation secondary to seborrhea. Some people call it seborrheic melanosis. It's not correct. You will not find the term seborrheic melanosis in any textbook of dermatology. It's melanosis secondary to seborrhea. Another condition where we find it useful is what you get the pigmentation at the edges of the nose, sometimes given the name nasolabial dysplasia, where there is a little pigmentation bit pointing out papules there, where again, oral small dose of isotretinoin might help. To move on, we have come to the important point which we have discussed already so far to a reasonable extent. Let's go deep into it, delve deeper. The dose that one would recommend, as it was pointed out for conglobate acne and severe nodular acne, we give zero point 0.5 to 1 milligram per kg body weight. For severe and moderate case of papulopustular acne, low dose, 0.1 to zero point 0.5. And for persistent mild acne, again, the similar low dose of zero point 0.1 to 5 milligrams. Now, these 2 points, the last 2 points, were not much taken into consideration, and only moderate consensus was given by the ERAISE study. Going to the case of slow responders, escalating the daily dose of isotretinoin. Now, the first point of it for clinical cure and prevention of relapse, I think, is quite clear. But to escalate the daily dose of isotretinoin in case of slow responders, I request my friend Somani, Dr. Somani, to please be more explicit on this, to escalate the daily dose of iron. How will you go about this?
Okay. Most of my patients, when I see them, I normally put them on about 0.4 to 0.5 milligram per kg body weight, and about majority, 80-90%, more than 90% respond to this treatment dosage. But there are a small subset of patients, about 5 to 10%, who still do not respond. In such cases, we might think of increasing the dosage slightly, and we can go to 0.5 milligram every day or 0.6 milligrams also in some cases if it is really required. So there are a very, very small subset of patients who need escalation of the doses, but brute majority will require only about 0.4 to 0.5 milligram. In Indian scenario, almost everybody responds. Maybe we may have to give it for maybe 5 months or 6 months or maybe a little more than that. But most of the patients respond very well to this mid-range treatment, not 0.2, not 1 milligram, but 0.4 to 0.5, in my experience, is the best dosage strategy, where we need to escalate very, very rarely, not very usually.
Dr. Manjunath, are you of the same opinion, or would you like to add something to that?
Yeah, I ditto. But only thing is, my dosage schedule of low dose, that is, I don't give 0.1, I give 0.2 to 0.5. There, 0.2, normally 0.2. That I'll transform it into a daily dosage is 20 milligram a day. I think most of our dermatologists are very fond of this 20 milligram per day. That is actually, if you see the body weight of many of our patients, is 0.2 to 0.5 milligram per kg body weight. So that is the dosage which I give. If they don't respond, that is when I can elevate the dose to say about 0.5 to 0.6 milligram. That is 30 milligram or 40 milligram a day. So rarely I go up to 0.1 milligram unless it's a conglobate acne or severe nodular acne, wherein we go up to 1 milligram per kg body weight. And yes, there are subset of patients, there are slow responders, wherein elevating the dose slightly from 0.2 milligram, if you're giving maybe 0.4 milligram or 0.5 milligram per day, it definitely benefits them.
Yes, incremental dosing or incremental escalation in the dosing of isotretinoin seems to hold the key, because it doesn't matter that whether we are diagnosing the type of acne on day number 1. It could be severe, it could be moderate, it could be mild. And it does no harm to the physician as well as to the patient. We start with a lower dose, and maybe in a couple of weeks, if we don't find the required results, we can most certainly increase incrementally. And to look at the administration once daily dose along with meals that is accepted fully, everybody knows. I don't think that needs any further elaboration. And maintenance, maintenance, of course, one has to be very careful about, and that gets individualized. Individualized meaning that depending on the response, we will have to continue or stop. Moving on. we spoke so much about low dose isotretinoin. What is our preferred fixed dose in such cases, and how long is the average treatment duration? And this dateline and timeline become very important because patients keep asking us that. How long do you want me to continue? Every patient asks that without fail. If not the patient's parents. How long? How long? Because they keep reading so much about isotretinoin and they are afraid of the side effects and they keep asking, what is your preferred fixed dose in such cases and how long is the average treatment duration? The next one would be, how do you balance between low dose and conventional dosing in terms of relapse risk, tolerability, and treatment duration? That I think we have already spoken and how we identify this. And what is the percentage of slow responders to isotretinoin that one encounters? Dr. Somani has already said about the very small percentage who really do not. Dr. Manjunath, what is the usual dose escalation done in these cases of slow responders?
Yeah, I think I just answered that question. So we normally see these slow responders, especially in this category of when papulopustular acne, and maybe in few nodulocytic acne, wherein I have not used adequate dosage. In such patients, they do show this thing. In any case, I won't be going 1 milligram per kg body weight. So probably I have used a dosage of zero point 0.2 milligram in such patients who are moderate acne, papulopustular acne, or with the few nodules and cysts. In such patients, I can elevate the dose up to 0.5 milligram per kg body weight or slightly higher, 0.6 milligram or so. So that I typically do it at a time with the first review. My first review typically happens at 4 to 6 weeks. So I generally give a timeline of 4 to 6 weeks for the response to occur. And that's when we decide. And what should be the duration of therapy? The duration of therapy all depends on the clinical outcome after giving isotretinoin. So typically the duration lasts for 3 to 6 months in most of our patients.
So nice. Now that we are talking about the duration of treatment, another important thing that crosses one's mind. We said that there can be incremental doses, and we spoke about that from slow responders. Now let's look at patients who have responded well, and then you say the dateline is there. How do we stop the drug? Do you reduce the dosage, taper down the dosage and stop the drug, or just stop abruptly, Dr. Samani?
Yes. I'll first start with the dosage. Like in India scenario, I don't feel that they need 120 milligram of cumulative dosage. In India scenario, 90 milligrams is the ideal cumulative dosage, if in my experience, and that is achieved when we are giving about 0.5 milligram per kg body weight for 6 months. Because if you give 0.5 milligram per kg body weight, it translates to 15 milligrams per month, and that becomes 90 milligrams over 6 months. That is more than enough to have a lasting remission and a long-lasting remission, and it works in absolutely most of the cases, 90% plus cases. So, or 0.4 or 0.5, depending upon the body weight. The duration, I normally see that the patients respond in about 5 to 6 months, like I just said, and I try to give isotretinoin 1 month beyond the clearance. If the patient responds in 4 months' time, I would give isotretinoin for 1 more month, and then I will stop it. And answering your question, I will stop it immediately because I don't taper it, and I don't see any reason to taper it because it just works wonderfully well. Remission lasts for quite some time, and only in case of relapse, we might think of starting isotretinoin again, either in lower dose or the same dose, or going for some alternative treatment strategies.
Fantastic and fabulous experience sharing. Thank you very much, Dr. Samani. Going on next, there was a low consensus around cumulative dosing targets, with experts divided between a treat to clear approach and a fixed milligram per kg endpoints. Now, I would like both of you to take this up and give me your guidelines on this. In your clinical practice, what signals guide you towards one strategy over the other? That is, whether you are thinking about dosing in terms of dateline, or you're talking in terms of clearance of lesions. Which one would you take as the first target? Dr. Somani?
Yeah, I mean, as Dr. Manjunath already mentioned, I would like to see the patient after a month or so, and that will decide, that will be the deciding time. If the patient is responding very well to the dosage I prescribed, I'll continue with the same dosage till I achieve remission. And if the dose needs a little escalation, I will escalate the dose if necessary. But most of the patients do respond to the initial treatment dosage. So I will look at the remission of the lesions, clearance of the lesions as my prime target to decide the dosage. If the lesions are clearing, the dosage is working very well. And one more point I will mention here is that the dryness of the lips. Some patients, they have severe dryness of the lips even with 20 milligrams of isotretinoin, and some patients have, a patient who's weighing 80 kgs will have dryness of the lips on only 30 milligram, and a 60 kg patient will not have dryness even with 40 milligrams. So I think dryness of the lips may definitely give a clue to how well the isotretinoin is working. So if the lips are very dry and cracked, that means that the isotretinoin is working very well. We might think of reducing the dosage by either 5 milligram or continuing the same dosage because it is very, very effective. Because the lips, I think, are an indicator, cheilitis, of isotretinoin working very well in that patient.
But Manjunath, which one do you take first, cumulative dose or the timeline?
I take treat to clear, that's timeline approach, because most of our patients would question later on, if I'm cleared, why should I continue? This is the problem with the patients also, as rightly guided by Dr. Somani. So a lot of patients do have adverse effects. One is the cheilitis, and they have dryness of skin overall, conjunctivitis. Some of the patients do develop conjunctivitis. So considering all that things, I think it is treat to clear approach may be ideal, but fixed milligram per kg has a very strong evidence. If some patients, they can understand this, if they are, if we can, my counseling is effective when when I'm more than convinced that only such patients I give, otherwise they stop coming to me. That's one reason, and probably that's the one which guides me, the both patient psych as well as the response, both together I consider to approach. But most of my patients are treat to clear approach. That's where I stand.
Yes, 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 yes. I agree with both of you, and it needs a lot of soft talking to the patient or the patient's parents regard this particularly when they come with this dryness of the lips. We do not know whether to continue treatment or stop and restart or to stop completely. We're always in a dilemma on that, which we cannot discuss in this forum because that will be individualized. That will be individualized, and we have to do according to the needs. Now, there was a consensus that there is no difference in the safety outcome between the use of conventional soft-gel capsule formulation and micronized formulation of isotretinoin. The second thing is there's no difference in the efficacy outcome between the use of conventional soft-gel capsule formulation and micronized formulation of isotretinoin. Here you find that there is definitely a divided opinion. Should we take this up, and how will you take it up, Dr. Manjunath? Have you tried both?
Yeah, I have tried both. I think there is no efficacy difference. It's only that it has got a better bioavailability. That's why the dosage is low. Otherwise, I think they are the same. The formulations, with the newer formulations and older formulation, it's the same. The bioavailability is higher. That's why the dose becomes less. Otherwise, there is no difference in the efficacy or adverse effects. That's my take. But although there are something to say that GI adverse effect may be slightly lower with the newer formulation. That's something which some people are, but practically in my clinical experience, I don't see the difference.
Your thoughts on that, my dear Samani?
Yes, Dr. Jack, I agree with Dr. Manjunath because both of them almost are similar in efficacy, in safety in my clinical practice. So I don't think it makes much of a difference between choosing between the two. So both are almost the same. So we can use either of them, but I normally go for conventional.
I too agree that the two of you are equally erudite and knowledgeable on this point. Thank you very much, the pair of you. Now, with regard to procedural interventions, comedone extraction is the talk of the town and almost a daily matter, and we also don't have to do it. The patient himself or herself does it. What about these peels? I find that to the younger dermatologists, first thing patient goes with acne, they say you have to do peels. You have to do peels. Next, of course, if they have the facility, laser procedures. Now, we won't go into laser procedures because that's not done by everybody. All and sundry cannot afford it and cannot do it. What about this superficial and medium depth peels, Dr. Somani?
Yes, I mean, in my experience, all these procedures are quite okay when you're treating the patients with isotretinoin. Comedonal extraction actually would be a good choice to do it especially in patients with comedonal acne, because that would prevent the initial flare if you do the extraction first or do a light cortiodiathermy before we start isotretinoin. Superficial medium depth peels and also the laser procedures are all, I think, okay when you're treating the patients with isotretinoin. And I agree with the general consensus that, okay, only for ablation or ablative techniques, we need to be a little more careful, and we can defer that for about 6 months or 2-3 months later after stopping the isotretinoin. Otherwise, all the procedures, I think we can definitely go along with isotretinoin therapy, which are quite safe, and it has been proved to be safe in so many studies till date.
Manjunath, your take on this, please.
Yeah. If the patient is on lower dose isotretinoin, the lower dose isotretinoin, there is no problem, because all these procedures which are mentioned here, either they are non-ablative or minimally ablative procedures. In non-ablative and minimally ablative at a low dose oral retinoids, there is no problem. But only thing is, we have to choose the patient, very right patient. If they're chosen, you have to look at all things, the type of skin and everything. Only then the decision has to be taken.
I'm glad you used the term that you have to choose the patient. That's the key. That's the key message when we talk about procedural intervention in acne. It's another additional, I won't come into that much. Now, what is recommended and what is not so strongly recommended? Let's look at this. I hope you're able to read this. Pre-treatment tests. Pre-treatment tests. Looking for dyslipidemia as one. Then, of course, examining for obesity, body mass index, and family history of diabetes, dyslipidemia, metabolic syndrome, fatty liver, lipid profile, liver function tests. Now, of these, as we already earlier said about the polyendocrine metabolic ovarian disease, certainly we have to do all of them. All of them we have to do. But which one? I feel the liver function test is very, very important as a pre-treatment investigation, and maybe look for dyslipidemia. What do my learned colleagues, Dr. Somani and Dr. Manjunath, think about it? Dr. Manjunath?
Yeah, my baseline investigations are dyslipidemia and the liver function test, because we know that almost all drugs, they are metabolized through liver. They can definitely, these are the two. Then other investigation depends on the patient profile regarding diabetes and the workup for metabolic syndrome and other things. That all depends on this thing. Liver function test and lipid profile, I believe they're the important ones.
Dr. Somani?
Yes, I agree with Dr. Manjana. Baseline investigation, LFT and lipid profile is, of course, mandatory. We have to go for it. Earlier, I used to think that it may not be required in all the cases, but now I have taken it up as a routine in almost all the cases where I want to put the patients on isotretinoin. Because in lean individuals also, I have seen triglyceride levels up to 300, 350 also. So it's always safer and better to go for these two basic investigations. And the other investigations depends, of course, upon other pointers and other markers. If you want to investigate for insulin resistance or want to investigate for other hormonal imbalances. But basically, yes, every patient should get it done, LFT and lipid profile, before the isotretinoin is started, and with a warning that pregnancy is, of course, not to be, pregnancy has to be avoided completely.
So it appears that all the three of us seem to agree with his recommendation. One thing that I thought is missing, but not essential at all. What do you gentlemen think about the free androgen index that has to be studied?
I think we
That
need,
is the total testosterone as well as the sex hormone binding globulin.
yes, That's a good prescription, good investigation to be done only when we are suspecting hyperandrogenism, or where we expect there is enough ground clinically and history-wise. Then definitely we should go for it and exclude that, because that would give us another avenue of treatment, and also it will help us understand the disease process clearly and treat it properly. Yes, it would be indicated in select cases where we really suspect that.
So we can reserve these investigations, which are quite expensive also, for patients who show clinical signs of metabolic syndrome. I
Yes.
think that would be a strong recommendation that we can do, and not do all and sundry for all the patients, which is recommended by the ERAISE study. This is just again about the lab monitoring, which we said just now, a universal protocol. What framework do you use in practice to decide monitoring frequency? How do you balance patient burden against safety, particularly in resource limited setting? That is what we just spoke about. And there's no point in asking the patient to throw his or her money around with investigations which are only of academic interest, and where it has proved to be, in certain cases only anecdotal reports. But the main basic thing should be the liver function test and the lipid profile. We agreed about all that. Other recommendations with regard to indications and contraindications. So contraindications, there is very little that we as experts should really offer for this, because already known that we all have to do look for other conditions, comorbidities, which we call correctly, depression and inflammatory bowel disease and pregnancy testing, patient counseling for female patients of childbearing. This we have been talking for age immemorial. I don't think even the audience will be much interested in that. If there is anything, they could always put it up in the chat box for us to discuss. Safety and monitoring. Let's spend a couple of minutes in this, please. Psychiatric screening before and during therapy received near unanimous support, yet the evidence does not confirm population level increase in suicide risk with isotretinoin. Let me be very, very frank. In all my 42 years of practice, and of course not 42 years of use of isotretinoin, maybe 30 years of use of isotretinoin, I've had only 2 patients come with the suicide risk, straight away complaining, no, doctor, I'm feeling feeling all sorts. Now, what has been your experience in this, Dr. Somani?
Yes, I agree with you, because the number of patients who have suicidal ideation or any depressive symptoms are extremely, extremely rare. Most of the patients, they don't have this problem, but still the fact remains that we must carefully evaluate the patient psychiatrically and see if the patient is having any kind of depressive symptoms. And in such cases, we might defer the treatment for some time. But as the recent reports have also pointed out, in fact, the depression is much less in patients who are taking isotretinoin even compared to patients who are not taking isotretinoin. So the depression and the suicidal ideation, I think it has a unnecessary hype which has been created earlier, and all the studies have clearly pointed out that the depression is not associated with the usage of isotretinoin. But still, to be on the safe side, we must avoid or defer in patients who are already taking antidepressants or who have clear signs of depression. But we must screen the patient before we start the treatment to be safe legally and also in the patient's welfare.
Dr. Manjunath, your take on this?
There is a very small risk, in my opinion, because I do come across some patients who said that they have an increased depression, that they had anxiety. Some of the patients, they said anxiety, but I'm not sure whether it is directly related to isotretinoin. But that keeps that red flag continuing glowing. So that's why I think it's important to take the history, pre-morbid history, prior to instituting isotretinoin. That's one thing. And second thing is also during the first visit, whether they have had a increase in the depression or anxiety. But having said that, I ditto Dr. Somani that what he said, they actually improve also. As the acne symptom improves, their depression and other things also improve. That is also, it is our this thing. But this is a drug which definitely scores way, way ahead, considering the risk of the neuropsychiatric morbidities that may probably be caused by the drug. So definitely the risks are much, much lower as compared to the benefit.
Yes, most certainly. Neuropsychiatric assessment, pre-treatment, I think is pushing it too far. As it is, patient is come for something which is almost physiological, and there's no point in pushing it too far. Pre-treatment psychiatric screening and things like that. But the second question, what are some practical counseling tips for female patients of childbearing age? Dr. Sumani?
Um, of course, as we as we advise every patient, we have to tell them that they have to avoid pregnancy positively. 100% they have to avoid pregnancy for, say, after isotretinoin therapy, and after stopping the therapy also, they must take precautions for about 2 to 3 months or 6 months to be on the safe side. And that is one practical point we have to clearly explain to the patient in the first visit itself. When we explain to the patient the duration of the treatment and also the time period where they have to avoid pregnancy. And that is one thing which has to be strongly advocated to the patient, advised to the patient about avoiding pregnancy completely. And that is, I think, the single most important point we must see as a practical counseling tip in childbearing age group.
Yes, first of all, ask the female patient whether she is married. If not, whether she is planning marriage.
Yes.
If not, tell her if she's planning marriage, be careful for the next 3 months. After we tell you okay, then you could go ahead. That becomes very important. 3 months in isotretinoin, and we talk about 3 years in isotretinoin. That's out of context now. Now, the post-treatment washout period for pregnancy remains contentious. This is what we just said. 3 months should be quite sufficient.
Yes.
Now, how are we going to implement this algorithmic approach to be adaptable beyond India to other skin of color populations? The question is, what aspects of the algorithm do you feel are most universally applicable, and where might regional differences in active phenotype, healthcare infrastructure, or regulatory environment require adaptation? Are there any positive points in this, Dr. Manjunath?
Yeah. I think they
You
have
do a
very
lot of
nicely.
traveling, even Dr. Samani does. Well, what do we look at? Regional differences in the acne phenotype.
Yeah, I think I agree with all these 3 points. Acne phenotypes definitely differ from the different ethnicity, healthcare infrastructure, obviously, and then the regulatory environment will require adaptations also. Because as we said, we always talk about marriage in terms of, we don't talk about childbearing age group. We always talk in terms of marriage, marriageable age. So there is a definite, the approach changes in such, say, we don't have such a fear, so much of fear that unmarried woman will become pregnant. That risks are very, very low in ethnicity like ours. So definitely that regulatory environment definitely requires adaptation, but somehow I still see that CDESCO and they generally follow the Western model, and they don't adopt too much. I think we need an adaptation, boldly adopt the things. And even the pocket insert, if you see the timeline is 6 months, which is mentioned, if I'm correct, still the pocket insert still maintain with 6 months. So when I say 3 months, often patients, we have a conflict about mentioned what we talk and what is mentioned in the pocket insert. So that conflicts has to be avoided. That's why we need to grow up, and we should tell that our regulation should change. Regarding healthcare infrastructure, I definitely agree. We generally do lesser investigations. So we don't do the entire set of investigation like hormonal profile, the metabolic profile, everything. We don't do it. So we do it what is necessary, but we give us so much importance to the clinical examination of the patient. The given patient, we do everything investigations based on a given patient. A case-to-case based approach is required here rather than a protocol-based approach, because the healthcare infrastructure is different here. And then again, the acne phenotypes, I think in the very dark rays, the cystic acne is very, very high, whereas we don't have we do have now, we have a higher incidence. I do see a lot of cystic acne, especially in boys, young boys, teenage boys. Conglobate acne also here and there, we do see the number is increasing. But definitely, I think this guideline, whatever is an effort to to make it more precise for our population. And definitely this is adaptable beyond India, especially the skin of color population. I agree fully with this.
I think you cannot take it, as you said, universally and globally. At least for the Asian countries, surely this can be taken into consideration. Having said that, I think it's time to pack up this session, which the three of us have been talking about. Let's see whether there are any questions in the chat box. We maybe could take up about half a dozen of them. There's one question. What is the youngest age to start isotretinoin in acne?
I think it's based on the clinical judgment. Although we start in 14 years and above is relatively safe, because that's the time we probably don't have to too much worry about bone-related adverse effect like early closure of epiphyses and hyperostosis. Of course, it is going to continue, but early closure chances may be less. So I think we can, but in a case where there is a justifiable, at much younger age group also, I have given prescriptions, but very much counseling the parent who has brought the child.
What about precocious puberty, Dr. Somani?
In cases where there is prepubertal acne or peripubertal acne, that is a headache to treat because the age is neither here nor there. We cannot treat the patients with antibiotics also. We cannot even give them isotretinoin also because they're just 12 or 13 years of age or 11 years of age. So in such cases, I think we just have to rely only upon topicals and the adjunctive measures like nice cleansers and moisturizers, which are non-comedogenic. That the case, and of course we need to investigate them thoroughly for any hormonal undercurrents, and maybe try to tackle that by yourself, or maybe refer to a colleague gynecologist and try to tackle that problem too. But this is a real situation where we have a little problem treating those cases, difficult ones.
Yes, 14 years should be fine, and if you're going to start earlier, regular monitoring is a must. Is there anything else in the chat box?
Yes, sir. There is a question on patient grade 3 acne has got anal fissures after isotretinoin. I think we have also seen, I'm pretty sure all of us have experienced. I think anal fissure can be managed with the topicals. If it's justifiable to continue isotretinoin or lower the dose, and if it is very severe, I think we should discontinue for a while and restart after some time. That is the approach I do in anal fissure patients who developed.
I'll quickly go through the questions. How and when to taper isotretinoin? We said that is out of question.
Yeah.
Can we combine low-dose isotretinoin, other aesthetic treatment like peels, carbon laser, etc.? Yes, we can. Why not? We can combine. If any of you have got some other view on, because there's already a study done by Mysore Venkatraman. I was also part of the study. We are combining certain forms of treatment. Now, here's the third one. If a patient with recurrent acne has prolactin 41, no, that is being technical, slightly raised, and others in the hormone profile are normal, treated with isotretinoin, spironolactone, chemical peels in the past, how to approach such patients and how to prevent recurrences of acne. The patient has also been referred to endocrinologists and been prescribed myoinositol with no much improvement. That's very, very sad, very unfortunate, with increased prolactin, and we know it's a PMOS and still not responding to spironolactone. You only have to wait for topically acting anti-androgens, which are slowly coming into the market in the form of clascoterone. I don't think any other opinions on this. I would love to hear from my
prolactin level is very marginally elevated here. Prolactin level is, I think even endocrinologist has not taken it very seriously. If you see the prescription, it's probably not such a worrisome. And other hormone profiles being normal, there needs to be, I think you should treat like any other acne. That is my take on this case.
Yes, we did talk about a bit of relief in pigmentation, facial pigmentation, particularly in seborrhea. There's one question of opinion, isotretinoin used in lichen planopigmentosis.
Lichen planus pigmentosis, yes, sir. I think it's
I think where the pigments drop into the dermis is not going to be affected. Now, when we spoke about melanosis secondary to seborrhea, it's all in the epidermis. It goes down to the dermis is not going to be affected. Now, even with escalating to 0.4 to 0.5 milligrams per kg over 5 to 6 months of isotretinoin, and later maintaining with topical retinol, there is a relapse. Should we give longer duration of treatment rather than 5 to 6 months? Dr. Somani, what do you think? I think we should.
Yes, you're absolutely right. We have to, because the dosage, the cumulative dosage is not sufficient. So we may have to extend the period and give for another couple of months or 3 months, and that will reach the cumulative dosage where the results will be quite effective and long lasting. We can extend. We must extend in such cases.
There is a question, Dr. Manjuna. The patient with grade 3 acne has got anal fissures due to isotretinoin. How to approach?
Yeah,
What are the other forms of treatment option?
I just took that question, sir, before that. I think basically in these patients, reduce the dose of isotretinoin, take an opinion from the surgeon, manage the fissure. Yeah, it is known. Fissures can occur in patients who are taking isotretinoin. It all depends on the severity and whether the fissure is manageable with the conservative approach. If not, you have to discontinue for some time and restart isotretinoin.
Yes. The next question also, I think we have already addressed about endocrine changes and delayed periods, etc. We have to start doing the relevant investigation or even send a patient to an endocrinologist. We've done the next one also, the younger stage to start isotretinoin. Is there a fixed gap that we have to follow between stopping tetracyclines and initiating isotretinoin? That's interesting. If you have started tetracyclines, is there a gap that?
Yeah, it said that a few days of gap. There is no clearly mentioned, if I'm correct. If somebody can answer it better than me, there are a few days. What I follow is about 4 to 5 days. That's all. We should not give them
money.
Yeah, I agree completely. There's not a big issue. Just a 1 week gap is more than enough because there won't be any cumulative effect. Cumulative effect will occur only when you use both of them for some period of time, 2 months or 3 months. Only then you can think of cumulative toxicity. But even if you don't give a gap, it's okay. But okay, to be on the safe side, 1 week gap is more than enough before we start isotretinoin.
Yes, for my reply, of course, is I don't even start on tetracycline, so it doesn't come to stopping.
Same with me. Yeah, but
So that's
someone else would have started.
Yes.
Patients have come. That is the thing.
Anyway, that's nice. Triglyceride level, isotretinoin should be stopped at what TG level?
Yeah, what guidelines say is, even if it is double, taking 150 milligram as a double, up to 300 milligram, there is no need to worry. Even up to 500 milligram, it says there is no need to worry. If there is higher than 500 milligram, there is a definite risk of pancreatitis. That's why we need to worry. Of course, the lifestyle modification and as needed, anti-dyslipidemic agent, anti-dyslipidemic agent can be added with the physician's opinion. So up to 300 milligram, primarily the lifestyle modification. Beyond that, there has to be lifestyle modification plus, yeah.
Last question, I think. Should all adult onset female acne be investigated for hormonal imbalance? Dr. Somani, is your answer yes?
Yes.
Or no? I also say yes. Dr. Manjunath?
Yeah, yes, because we don't have anything to treat. Very tough disease.
I love to share one of my path-breaking articles on hormonal acne, which came in Medscape Dermatology. If you do find the time, please go through it. It's a nice article. It was in the year 2012 that it was published. So, Dr. Ashley, are we done with the questions?
Yes, sir. Yes.
So, not bad. I just finished on time.
Yes, perfect.
You must say congratulations to me also, and the panelists for finishing on time. And really very thankful to the audience for limiting the questions to such relevant matters, and which are so useful in day-to-day practice. I must also thank my good colleagues, and I repeatedly say erudite colleagues, Dr. Manjunath Shenoy and Dr. Vijay Somani, and at the same time, thank everybody from CIPLA, including the technical team, for giving me this wonderful opportunity. And it's time for us to say bye-bye to all. Thank you very much.
Thank you so much. Thank you very much.
Thank you, sir. I just want to quickly hand it over to Rohita from our marketing team for the formal.
Yeah. We will not stop in between. Yes, Rohita.
Thank you so much, sir. On behalf of CIPLA, I would extend my sincere gratitude to our esteemed moderator, Dr. Jaikar Thomas, for leading today's enriching discussion with his invaluable expertise. A heartfelt thank you to our distinguished panelists, Dr. Manjunath Chinoy and Dr. V.K. Somani, for sharing their insightful perspective, or I would say Indian insightful perspective and practical clinical experience and expertise. So thank you to all the doctors who have spared their valuable hours in a Sunday morning to join this session. We truly appreciate your participation. With this, I would like to conclude the session, the webinar, and thank you so much. Have a wonderful day ahead.
Thank you.
It's been a pleasure. Anytime.
Thank you.
Look forward to meet you in person as well.
I too. Okay.